Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about vacuum delivery or ventouse delivery. Okay? So, what we wanna discuss today? The definition, the prerequisites, indications, contraindications, classification of vacuum delivery, what is the technique of vacuum delivery, and what is the complication of vacuum extractor. As you see in this picture, this is different shapes of vacuum delivery in the upper one, and here the cup is applied to the fetal head and the traction is done. Okay, let us go on to the definition. What is the vacuum delivery? This is an operative vaginal delivery. So if anybody asks you what is the operative vaginal delivery, we have vacuum delivery and we have forceps delivery. Okay, we are talking today about the vacuum vaginal delivery. Okay, so it is operative vaginal delivery is used to expedite vaginal delivery for either maternal or fetal indication. So I have a maternal or fetal indication like distress, for example. I wanted to shorten the second stage. I wanna to shorten the second stage in maternal disease like cardiac disease or pulmonary disease, or I have maternal distress or fetal distress, so I'm using vacuum delivery to expedite vaginal delivery. Okay, so I use an instrument like that in the picture. This instrument aiming for what? Applying a cup to the fetal skull. This cup applied on the fetal skull with negative pressure will cause artificial cabot or what's called shaking. Will help the cup to be attached to the fetal skull. Then do traction. With traction, there is descent and the rotation of the fetal head and helping extraction and delivery. Okay, so this is the aim of using a vacuum. What is the prerequisite? Very important, really. The prerequisite: the cervix should be dilated, fully dilated cervix. The head should be engaged. The bladder should be empty. The patient, of course, should consent and she should share in the decision of using vacuum delivery and taking her consent. This is very important. Anesthesia available, like epidural anesthesia or another type of anesthesia. Operative theater available because I may need cesarean section if vacuum delivery failed. Okay, there must be no cephalopelvic disproportion, so the pelvis should be adequate and the fetus should be of average size, no macrosomic baby. Okay, there is available assistant to help the obstetrician who are doing this process of vacuum delivery. The baby shouldn't be preterm because it is very dangerous for preterm baby to apply vacuum delivery because may cause intracranial hemorrhage and so on. Okay, so it will be more injurious for preterm, so the baby shouldn't be preterm, especially not before 34 weeks gestational age. Okay, this is the prerequisite. So what is the indication? Maternal distress, fetal distress, prolonged second stage of labor, or I want to shorten the second stage of labor because woman has cardiopulmonary disease or neurological disease and so on. Okay? Okay. So what is the contraindication? Non-vertex presentation. Non-vertex presentation is a contraindication for using vacuum delivery. Also, fetal bleeding disorder like hemophilia, thrombocytopenia, von Willebrand disease, because the possibility of intracranial hemorrhage is very high, of course, if you are using vacuum. Premature fetus, less than 34 weeks gestational age, Suspected fetal macrosomia, another contraindication. Second degree cephalopelvic disproportion is a contraindication for using vacuum. Fetal death. Why fetal death is a contraindication? Because as you see, while we're applying the cup, we need the formation of artificial caput, and this will not be formed if the baby is dead. So the cup will not be attached very well and not will be fixed to the scalp because I miss this chiglon or artificial cup. Okay, another contraindication is the fetal anomalies like osteogenesis imperfecta. So what is the classification of vacuum delivery? I can divide them into three groups. The easiest one is the outlet delivery, then low delivery, then mid delivery. Of course, the head in all of them is engaged, but there is some difference between outlet, low delivery, and the mid delivery. Let us see the difference. In outlet delivery, the scalp is visible at the introitus without separating the labia. The fetal skull reached already the pelvic floor or on the perineum. You can say the head on the perineum. The sagittal suture is in anteroposterior diameter or right occipital anterior, left occipital anterior, or occipital posterior position. Rotation doesn't exceed 45 degrees. This is the outlet delivery. What about low delivery? The leading point of the fetal skull is at station +2 or more and not on the pelvic floor. It doesn't reach yet the pelvic floor. If it reaches the pelvic floor or the perineum, it is called outlet delivery. But in low delivery, it doesn't reach the pelvic floor yet, although it is engaged and +2 in station. Okay? Without rotation, rotation is 45 degree or less. But what if with rotation, rotation is greater than 45 degree? Okay, what about mid-delivery? Here, the station, the fetal head engaged already, but the station is above +2, but the head, as I said, engaged. Okay, what is the composition of vacuum extractor? Look to this picture, please. Here is the cup, metal cup of different size, maybe 4, 5, or 6 centimeter, or celastic cup, silicone rubber cup, which is less injurious to the scalp of the baby. Okay, but the metal cup is more suitable for if there is large caput in the fetal scalp. Metal cup will be more suitable, but it is more disfiguration for the fetal scalp than celastic cup. Okay, so cup, metal cup or celastic cup, rubber tube like this one, rubber tube. Okay, pump like this one, bottle like this one. This bottle, vacuum bottle made of glass, has 3 outlets as you see. 1, 2, 3. 1, 2, 3. 1 is connected to the pump. Okay, 2 is connected to manometer to measure the negative pressure, which shouldn't exceed 0.8 kilogram per square centimeter. Okay, this is the manometer. Okay, the third outlet is connected to the tube of traction cup, this one. Okay, so 3 outlet, bottle, cups, pump, manometer. This is another shape of vacuum delivery. Here, suction is done with this instrument. This is the manometer. This is the rubber tube. This is elastic cup. What is the technique? Technique of vacuum delivery is very important. Patient in lithotomy position, bladder empty, all prerequisites, as I said before, is already done. Consenting of the patient, the baby of average size, no cephalopelvic disproportion, and there is good uterine contraction and the head is engaged and of course vertex presentation. Okay, the vacuum cup is applied to the fetal scalp. The cup is placed symmetrically astride the sagittal suture at the fetal pivot point. You will apply it astride to the sagittal suture at the fetal pivot point. So what is the fetal pivot point? It is 2 centimeters anterior to the occiput and 6 centimeters posterior to the anterior fontanelle. So as you see, I should be away from the anterior fontanelle because it is very dangerous. If you applied it by mistake to the anterior fontanelle, it will cause intracranial hemorrhage and the injury to the brain. So please remember, we will put it on astride on the sagittal suture at the fetal pivot point where it is 6 centimeters posterior to the anterior fontanelle or 2 centimeters anterior to the occiput. Okay? Okay. Correct placing of the cup is very important. Why? Because it will assist flexion, descent, and the rotation of the vertex when traction is applied, and also minimizing the risk of injury to both fetus and the maternal soft tissue. So correct placement is very important. Okay. Before applying suction and inducing the negative pressure, it is important to sweep finger. Look to this picture, please. I'll move the finger of the other hand all around the cup. Why? To be sure that there is no intervening cervical or vaginal tissue between the scalp and the cup. Okay? So move your finger all around to be sure there is no intervening vaginal or cervical tissue. Okay? Okay. Then ask the assistant to start using a pump for negative pressure, suction. Okay? How to start negative pressure? Start gradually. This is the most common use. You can start gradually or rapidly, but gradually is better. Rapidly if you are in a very emergency situation. Okay? What does it mean gradually? A negative pressure start with 0.2 kilogram per square centimeter applied, and the cup is rechecked for position and the possible entrapment of maternal tissue. So you apply negative pressure 0.2 kilogram per square centimeter. Then again, like this picture, be sure that there is no intervening tissue between the scalp and the cup. Okay? Then gradually increase the negative pressure, increase suction. 2 minutes in 0.2 kilogram, 2 minutes in 0.4 kilogram per square centimeter, of course, 2 minutes in 0.6 kilogram, then reaching another 2 minutes 0.8 kilogram. So I'm starting the negative pressure gradually, 0.2, 0.4, 0.6, 0.8, and then each station or in each level we give 2 minutes. Okay? Okay. This is called the gradual suction. The gradual suction. Why I am doing this suction? This gradual suction will cause artificial caput, which is called Chignon, will help in fixation of the cup to the scalp. Okay? Okay. Or if I'm in a very emergency situation, there is fetal distress, I can't wait all these minutes, so I'll do the suction rapidly. Okay? Okay. Then do downward traction. Downward traction along the pelvic curve using the dominant hand. And the traction is applied during contraction and during maternal bearing down. So do traction while you encourage the lady to do bearing down and during uterine contraction, because this force will help in descent of the fetal head. What about the other hand? The other hand, as in this picture, will help in fixation or prevention of detachment of the cup from the fetal scalp. As you see, we are doing pressure on the cup, so to prevent the detachment of the cup from the fetal scalp. Okay, and also the rule of this left hand is to follow the progress of descent, monitoring the progress of descent. Okay, so this is the other hand, while the right hand, if you are a right-handed person, doing a traction downward. The left hand do counter pressure to the cup, as you see in this picture. Okay, when the fetal head is crowning, the suction is removed and the cup is detached. Okay, as in this picture, I removed, suction is removed and the cup is detached because crowning happened, and the head will be delivered and the body as usual. What if a problem happened during traction that the device disengages, the cup detached? Okay, so try another attempt. Okay, how many trials I can do? I can do from 2 to 3 attempts. If failed, there is no more trial. Okay, okay. Which is better, soft cup, elastic cup, silicone cup, I mean, or metal cup? Usually less injurious to the scalp is the soft cups, like elastic silicone cup, rubber cup, okay? However, as I said before, metal cup is better if there is large caput in the fetal head. What is the complication of the vacuum extractor as regard the maternal and fetal one? Yes, cervical, vaginal, and the perineal laceration can happen, but of course, if it happens, it is less than what may happen if you are using forceps delivery. So vacuum is safer as regard the injury, maternal injury, cervical, vaginal, and the perineal laceration. Okay, okay, but it may happen with vacuum. Postpartum hemorrhage, manual removal of the placenta may happen if you are using vacuum extractor. So there is increase of risk of manual removal of the placenta, puerperal complication also. Okay, what is the fetal complication of vacuum extractor? Cephal hematoma, ulcer and bruises of the fetal skull, intracranial hemorrhage, neurological injury, or retinal hemorrhage. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and the Gynecology Faculty of Medicine, Mansoura University.